Good afternoon, everyone, and welcome to the Hunt Institute Early Efforts webinar. We are joined today by Dr. Jana Singleton, who is with us she is the Chief Clinical Services Officer and Chief of Pediatrics at Beaufort Jasper Hampton Comprehensive Health Services. Dr. Dina Leeser is the Senior Advisor for the Early Childhood System Strategy at the Health Resources Services Administration. And Dr. Laura Jana is the Chief Innovation Officer with the Evidence to Impact Collaborative at Penn State University. I'm Holly Hickson, and I am the Deputy Director of Early Learning at the Hunt Institute. Thank you all for joining us today.
Thank you.
Before we begin, I want to go over a few quick housekeeping items. Later in the hour, we will share some of your questions with the panel. If you'd like to contribute a question, please use the question and answer function in the Zoom toolbar. Also, please know that today's session is closed caption. You can also access those settings at the bottom of your screen. Finally, you will be able to find the recording of today's webinar on our YouTube channel within the next few days. You just go to YouTube and search for the Hunt Institute. So I'm going to kick off today by opening up with Dr. Jana. And in 2018, you presented a TED Talk on skills every child will need to succeed in the 21st century. I was wondering if you could highlight a few of those skills here and discuss the role of the pediatric community in fostering those skills.
Well, sure. And it's great to join you and to join everyone. I'm a big fan of the Hunt Institute's work, so this is a particular honor. Yeah, so, I always feel the need, both as a pediatrician and somebody very active in the early education sector, to start out by saying why it was I targeted skills in the first place. And amongst people who focus on early childhood development, I will admit right from the start, technically, they're not just skills, because a lot of people think of skills as, like the sort of literal technical training type of skills. What I was talking about was more of the soft, non-cognitive and other skills, competencies, transferable skills, those sorts of things. But I also recognized that they did not get treated with equal respect as what I call, and again, I call it IQ skills, not technically IQ, but IQ skills, which would be like the reading, writing, arithmetic skills. As a pediatrician, what I actually was attempting to do when I set out to talk about what skills all children need to succeed, because everybody likes children to succeed, was I was particularly focused on the increasing amount of information we had about early brain and child development and translating that out into the real world, into practice, making sure people understood it and could make use of it, but in particular for children born into poverty and facing adversity. And how do we change what we all recognize be somewhat dismal life trajectories? And so what I did was I realized, I could talk to early educators and pediatricians and parents and social services sectors really easily. It was like preaching to the choir, but how would we get business and policymakers to pay attention and actually invest in the space? At which point I said, what is it that everyone and their second cousin wants to talk about? And it was skills. Now, if I said social emotional skills and life skills, that sounds warm and fuzzy. And for anyone in early childhood, that's great. But for everyone else, it's like you get a pat on the shoulder. You must be a very nice person working with, toddlers about those nice, warm and fuzzy skills. So what I did was I took a list of skills that kept coming up in the adult world, in the world of work and entrepreneurship and leadership and innovation. And if you'd like, now that I've given the talk many times, it was communication, collaboration, teamwork, adaptability, resilience, grit, perseverance, emotional intelligence, the ability to fail and adapt. And everybody nods their heads.
Yes.
All I did was I said, let me show you what those skills look like during the first 5 years during their foundational development. And what does it take to help with those skills? And because this is a pediatric discussion, and the topic being about optimal development and how it relates to early education and early success, early childhood development is the bread and butter of pediatrics, but it's also the bread and butter of early education, childcare. And I started saying it's one and the same, like we're all after the same thing. And all I did then was I packaged those skills into an easy framework that was meant to encompass all of the research and things that we had. So I won't belabor the point and go into the specific skills, but the framework I created was a set of skills I called key skills, but QI, like chi, sounds like key. That's good in case people aren't paying attention. They still think they're important. But they're meant to be very easy to remember and capture all of these soft, non-cognitive, and other skills that we all know are super important, but that kind of get pushed aside. When push comes to shove, that's not what we test for. That's not what we kind of hold people up for. And then ultimately, we wonder why children don't have those skills. So I'll leave it at that for now, and we can always discuss more later.
Wonderful. Thank you, Dr. Jana. And Dr. Singleton, as the Chief Pediatrics at Beaufort Jasper Hampton Comprehensive Health Services in South Carolina, how do you feel the pediatric community there prioritizes the holistic needs of their families and the children that you serve?
Like Dr. Jan, I want to say hello. And I know our organization has a long name. It's Beaufort Jasper Hampton. Beaufort is North Carolina.
Oh, I apologize.
It's
I'm a
Beaufort.
Michigan girl at heart, so you might be getting an interesting pronunciation there.
No worries, no worries. But
Thank you.
we are a community health center. And so our whole premise is to provide community health care, understanding that healthcare is not just that. I always say that me in the 5x5 box for 15 minutes. But it encompasses everything. Like the things that Dr. Janet just discussed, all of that goes into how I am able to take care of myself and how I show up in my community. And so we at our Beaufort Jasper, we call it Beaufort Jasper for short. We at Beaufort Jasper, one of the things we do at throughout our pediatric care is we do screening for social determinants of health. So we look for those things that could affect our healthcare outside of our work, outside of just the actual healthcare, and we provide resources for that. We provide, English not being your first language is also a barrier that can get in your way. And so we do our best to provide in-person translation, especially for our Spanish speakers. We hire interpreters because we understand that the over the telephone and over the laptops are great, but it's better to have a one-on-one person, especially if we can. So our Spanish speaking population is our biggest population of non-English speaking patients. So we hire interpreters. We also participate in programs like Reach Out and Read, because we try to push those things home that address, go home and do this with your child. Yes, we are talking about what's going on right now in my box, but outside of my box, how can I interact? And how reading is more than just reading, but it's interaction, it's quality time, it's family time. We have a Parents as Teachers affiliate, a Blue Ribbon Parents as Teachers affiliate, actually, that does home visiting and helps bridge that gap between what we talk about and what actually happens in the home. We provide transportation services for our families because, again, barriers to healthcare, I can't get there. We do telehealth services, barriers to healthcare, I can't get there. And then we as a community health center like to host community events so that our families can see us outside of the office. So we're not just part of a healthcare system, but we're part of a community. So we'll do things like we have a child abuse prevention festival that's coming up later this month. We do flu vaccines. We do back to school physical drives, not just for sports physicals, but an actual let's get your well child check done, physical drives before the summer comes up. We do, what else? Oh, I feel like I'm missing something. Oh, Halloween. We do things, we do creative things. We do a trunk or treat for our kids in Halloween.
Oh.
We have school-based clinics that, okay, again, you can't get to me, but I can come to your school. So we have school-based clinics that do all of those things. So for us, it is a community-centered thing. It's a holistic approach, because we understand that we can't be what you need in that 15-minute time frame, but we can help support you outside of that 15-minute time frame so that we can have better outcomes in your health and better outcomes in your school development. They're, like Dr. Jana said, they're intertwined. You can't take one away from the other one.
Dr. Singleton, everything you said just resonates with everything I believe in strongly. Thank you. And I also love the quote about laps. The best laptop in the world is on a parent's lap when you're reading.
Yes.
So yes, that's how we learn to read. It's beautiful. Dr. Lisa, you're the senior advisor for early childhood system strategies at Health Resources and Services Administration. I was wondering what is your view of what is meant by an early childhood system, and what is the role that pediatric practices plays within that system?
Great, thank you so much. So an early childhood system advances policies, practices, partnerships, financing strategies, and supports the needed leadership and infrastructure across state and local levels to promote strong and nurturing relationships between caregivers and children, address sources of family stress, and work to really move upstream and promote early development and family well-being so that each and every child and family can flourish starting prenatally. This means really so aligned with what my colleagues, who I'm so honored to be on this call with, are sharing, building upon that sense that it's a holistic approach, right? And aligned with that, that takes a cross-sector approach to meet those holistic needs of children and families. So this means taking a really wide two-generation whole family view of the sectors that are part of such a system. For example, ensuring that health, economic support, child welfare, and family support partners, as well as early care and education, are working and others are working strategically towards a common vision and holding the population view at heart. It also includes parents, providers, and community leaders as key partners and leaders in systems design and development. And a well-functioning early childhood system reaches families with early, universal promotion, prevention, and more targeted and indicated supports and services, improves the coordination of the services and supports, and is constantly moving towards promoting a climate of commitment and support to early childhood. Because so many of our policies and financing strategies don't really align with those upstream approaches that we know are necessary. My favorite question of pediatric practices can play such an important role in the system in partnership with others. The health system, especially pediatric primary care, has such strong potential to advance child health, school readiness, and family well-being, and provide or connect families to developmental services due to its near universal reach at early ages. And so I also want to just put, Dr. Singleton pointed out, was such a great example of that broader connection to other services and really recognizing that. So in particular, why well child visits, why that can be such an important lever and partner for that pediatric role. They're paid for and monitored in performance accountability systems for Medicaid, health plans, and health systems. There are currently 15 pediatric well child visits that are recommended in the child's first 6 years of life, and really front loaded in that early age, including a recommended visit prenatally. And that well child services and encounters with professionals, so they become what in our current climate and country, the most accessible portal into young families and children before entering preschool, providing that opportunity to develop trusting relationships between providers and families, promote child and family strengths, and coordinate and link children and families to concrete supports. And yet, really building again upon what was shared, it is important to recognize the power and potential universal reach of that system, and yet only about half of the visits that are estimated to take place each year occur, and the biggest gaps are in the children and families most impacted by various challenges. And pediatricians cite lack of time, staff, knowledge, and sometimes even awareness of and ability to connect with various community resources as barriers to promoting early development, screening and connection to resources, effectively addressing those social drivers of health. So again, it can be such a critical partner and part of an early childhood system, but it really takes that holistic an upstream, equity-driven, comprehensive approach.
Right. Are you able to hear me now? Wonderful. Thank you so much, Dr. Leeser. As a reminder, we are taking questions in the Q&A box, and we will be getting to those in just a little bit. If you have any questions, please go ahead and keep adding those into the Q&A field. So I'm going to move on to our next set of questions. Dr. Jana, in your book, The Toddler Brain, you speak about families recognizing the connections that exist between their own parenting behaviors and their child's ability to acquire valuable 21st century skills. How do you feel that the pediatric community can support families in this understanding and journey?
Well, I think it's a great question. And on the one hand, I always feel like it's a bit obvious for those of us who are pediatricians or in the pediatric community, because, you know, as somebody who trained in what I always say, the hard sciences, right? I was cellular molecular biology and neuroscience and very academic medicine, born and raised. But I also realized very early on as a big fan, and I trained with one of the founders of Reach Out and Read. So as somebody who spent time talking about reading books with babies and doing all these other things, you know, I think in the pediatric world, we're all very accustomed. Anybody who's a good pediatrician is not just talking about antibiotics and cells and diseases and things, but helping parents, not just teaching them the facts about whether it's early brain science and the benefits of talking and cooing and singing and playing and reading books to babies, but having them get a feel for just how important and how exciting what they stand to do as parents is. And I think that's a lot of it's building parents up. You know, Dr. Singleton addressed a bunch of the issues. Dr. Leeser, I mean, we all look at this and say, what stands in the way of a parent having this really good relationship with a child? And it's nice to have a parent and child relationship that's really strong. But what I also often emphasize is write down, it's so important. It's like right down to the level of connecting neurons in the developing brain, right?
Mhm.
And calling, and again, it's parents, but it's also early educators, and it's anyone who's the caring, responsive adult interacting with young children. Because again, I was focusing on what happens if you don't have caring, responsive adult, what happens if you don't have, you know, high quality early childhood education experiences. How do we make sure all children do? You know, Dr. Leeser mentioned the words, and probably Dr. Singleton did too, because we all recognize now the importance of this relational aspect. A lot of people think that you go into pediatrics because you like children, which we all do. But to really be effective, it is very clear now, and all the evidence supports the fact that you really need to help build adult capacities to improve child outcomes. You can't just kind of put your blinders on for the child. And so looking at what stands in the way, whether it's language, transportation, all the social determinants of health, that's why they're so important. So in terms of making this very concrete for parents, one is to build up their sense of that they are able to do this. And it's not just a matter of money and status and degrees, but that a caring, responsive adult, and I always emphasize, because I get misquoted sometimes, responsive adult. Responsible is a judgment call, and it has all sorts of implications that can be taken in the wrong direction. But a caring, responsive adult, even if they're illiterate, even if they don't have a job, even if they don't speak, you know, English and their children are trying to do well in school in English or whatever it is, that if they can be caring and responsive, and I literally mean talking, cooing, singing, playing, reading books with babies, that is like the single most important thing. And when I mentioned that I focused on skills, I actually, for both the Toddler Brain and the TED Talk that I gave related to it, I focused on two things. I said skills, because that let me capture all these concepts about executive function skills and emotional, you know, relational aspects and curiosity and creativity. But the other piece was a caring, responsive adult. So it does not matter if the audience that I speak to, whether it's in my writings or my speaking, doesn't matter who my audience is. It can be global business leaders, the World Bank, the US Chamber of Commerce, or it can be pediatricians and parents and early educators. I close every talk saying, okay, if you buy into this concept, and so far everyone has, there's these skills we all know we care about. Nobody questions that we care about those skills, and that you need a caring, responsive adult. And it's really hard to argue with all of the literature and evidence base that we have showing how important that is. My punchline at the end of every talk is, well, what does it mean for the children who don't have it? Right? if they aren't in the environment or if they don't have it, what can we do? And that gets to Dr. Leeser's point, like the systems level discussion of what you need to do and collaboratively, and to all of Dr. Singleton's examples. To me, that all ties together of how do we make sure that you have a caring, responsive adult nurturing these sort of lifelong, life-enhancing skills. And I always say for success, which some people interpret as business success, that's great. If you have a good job and you're successful, I'm happy for those children. But my definition of success is thriving, being a contributing member of, society, not, having a roof over your head, having food, whatever your definition of success is. I want all children to thrive. So that's how I approach it.
Thank you very much for that answer. Dr. Singleton, you are also the lead clinician for Parents as Teachers program. Can you tell us a little bit about why you believe home visiting programs such as Parents as Teachers make a difference?
I get to talk about Parents as Teachers is one of my favorite things to do. But first, when Dr. Jana was speaking, what came to my mind was Frederick Douglass's quote, "It's easier to raise strong men than to mend broken ones." And so that's what we're doing here in early childhood and pediatrics. We're trying to raise strong people so that we're not trying to fix them on the other end. And it doesn't always work. But home visiting, I get to talk about it. It was new to me when I, having come out of residency and started working and not having home visiting when I first got here. I knew it was good, quote unquote, but I didn't get to know all of that, what entailed, until we were able to bring the Parents as Teachers affiliate here, and I became the medical director. And it has opened my eyes to just how important home visiting and other programs like Parents as Teachers are for developing children. I just go back to my patients, my personal patients. My first real kind of look into it, I had a patient who was premature, came out of the NICU with an apnea monitor. Well, I always explain it as a medium-sized textbook that mom has to carry around with her 24/7. And of course, she had all these follow-ups with these specialists. And me in my box said, "Mom, you got to do this, 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 this." And she wasn't doing any of it. Well, I got her involved in our Parents as Teachers program, and I learned so much. Mom didn't have stable housing. Well, if she didn't have stable housing, how is she going to do the things that I'm asking her to do as a pediatrician? And it's those types of things that groups like Parents as Teachers and other home visiting groups get to do. I say they bridge the gap, but they necessarily don't bridge the gap. They light that pathway for families so they can have that go-between. They understand where they are and where they need to be, and they help light that path. They light that path with resources. They light that path with support. They light that path with building up mom and dad and caretakers, grandparents, whoever it is, and giving them the confidence. Sometimes when we get all bogged down with the things that we have to do, like making sure there's food on the table, making sure that the place is clean, or we have a place for it to be clean. That tunnel vision comes on, and all we see is the problems, the problems, the problems. And when that happens, unfortunately, our children get pushed aside, not because we don't love them, but we're doing what we know to show that we love them. We're making sure that they have stable housing. We're trying to make sure that they have food to eat. And all of that is great. We need all of that. But how can I get that one-on-one time that Dr. Jana mentioned when I'm so focused on being able to just provide the basic needs to live? And home visiting programs allow us to help, or allow those programs to help those people provide those basic needs. Let me help you provide those basic needs. And for programs like Parents as Teachers, while I'm helping you do that, let me also show you what the importance is of reading is to your child. What the importance is of being your child's first teacher. I like to say Parents as Teachers is just that, understanding that you are your child's first teacher. And how does that look? What little things, we always want to buy the kids things. What little things you have around the house that you can use right then in that space to expand those minds, let those neurons fire, and get everything that developing brain needs. So when they do go into school, it's like, oh, I've seen this before. Oh, this looks familiar. oh, I did this with mommy, and those neurons continue to fire even more. So the more I learn about home visiting, like I say, now I get the privilege to speak about home visiting. I sit on the board for the National Parents and Teachers Organization because I've realized how important that type of work is. And it only enhances the work that I get to do as being a pediatrician. And so it's exciting for me.
Your joy just exudes through the screen. I love listening to you talk about that. Parents as Teachers is one of those programs that is so strength-based and so relational. We talk so much about the importance of relationships with infants, and we forget about the relationships with adults that we need to build as well and trust. So thank you very much. Dr. Lee, sir, the next question's for you. Just a quick second. Working in support of the Maternal and Child Health Bureau's vision of an America where all mothers, children, and family are thriving and reaching their full potential, how do you see the intersects with the pediatric community for school success and optimal child development?
Thank you. So the Maternal and Child Health Bureau, or MCHB, is the one federal bureau whose mission is to improve the health and well-being of all of America's mothers, children, and families. And we envision that America where all children and families thrive and reach their full potential. To do that, we use a strategic plan that guides our work. And that plan includes 4 areas of focus under access, equity, workforce capacity, and impact. And under that strategic plan goal area of access, some of those core objectives include monitor and improve equitable access to a continuum of high quality prevention, early intervention, and treatment services that address medical and social drivers of health across the life course. Strengthen state and community-based comprehensive systems of care for maternal child health populations that equitably improve well-being, and accelerate implementation and adaptation of preventive services in medical homes and other settings for MCH populations. That enthusiasm, did ring through. And when you think about, as pediatricians, also I did not really hear anything about home visiting, evidence-based home visiting during my training. And I'm so privileged to sit in the Division of Home Visiting and Early Childhood Systems, realizing, the impacts and the return on, and the impacts of home visiting and how we can function in partnership with pediatric care there. And do want to note that, back to sort of the core of your question, that full potential in families thriving, I want to note that working towards that shared vision, to really center that as a core goal for our systems to work towards thriving children and families. And also note that MCHB supports the National Survey of Children's Health, and there is state level data that is available around child flourishing, around healthy and ready to learn, around family hope and resilience, as well as other systems quality and access elements that are so key to that thriving and reaching of full potential. In part, how we do this too at the MCHB level is we operationalize this commitment, for example, by supporting a program called the Transforming Pediatrics in Early Childhood program, which was really developed to address some of the gaps that I highlighted earlier around realizing the potential of the pediatric health system in promoting that very, optimal development. And the purpose of that Transforming Pediatrics in Early Childhood program is to support, spread, and scale the implementation and equitable access to what we're calling the early childhood development continuum of care that has that whole family, 2-gen upstream promotion, prevention and screening, linkage to services, intervention, and really brings that together, including, again, that connection and coordination. We're currently funding 8 states to do that work at sort of with a lens towards a system level, because so often, you'll have this amazing champion of a pediatrician in one pediatric practice working so hard to bring a particular opportunity or intervention. So how do we really spread and scale this as to offer our children and families the opportunities that, are possible from the very beginning. We also think about this at the broader state systems level and fund our early childhood comprehensive systems program that right now the iteration of this work is the early childhood comprehensive systems health integration prenatal to 3 program that really tapped into this long-standing fragmentation between the health system and that broader early childhood comprehensive system. And there are some 20 states are being funded to advance work to really improve that coordination, as well as, really promote that early and equitable access to that continuum of care. And, we're really trying to think about how can we support national leadership to really bring these concepts and, present. There's so many opportunities. And we have recently funded some work in Mississippi that was focused on developing an early childhood developmental health system. And something called the Engagement and Action Framework was developed that was focused on how can we improve those population level outcomes in child flourishing, school readiness, and family resilience? And how can we really start to think about a through any door approach that leverages the health system in partnership with community partners and access points to be working together, but starting with focusing on focused areas of opportunity, like bringing to scale those whole family health promotion opportunities, leveraging Bright Future's best practice guidelines around child health, and really bringing them to reach all children and families, recognizing that there are many trusted touch points within the community, and there has to be coordination and linkage between the health system and that broader array of partners. And we also are funding right now an early childhood developmental health system evidence to impact center to do some work deeply in 3 states to try to really spread and go deep within this kind of model, but then to bring some of that further, bolster some of that national leadership and dissemination of these concepts and resources. And I'm also very proud and excited that we know, we have to do this together across all levels, federal, national, state, local, communities and families. And we recognize these opportunities at the federal level to both facilitate this kind of approach. And then there are places where there are barriers that we learn are present at the state and local level, and how can we address them? So we partner to conceptualize and support what we call the Early Childhood Systems Collective Impact Project that has yielded a set of recommendations for federal action to really move towards this system, because there are so many agencies and programs at the federal level that touch that, children and family and communities and really can impact positively or negatively thriving. And my last comment, and thanks for opening the door around home visiting, is, right now, the maternal, infant, and early childhood home visiting program was recently reauthorized and experienced an increase in funding. And there's a match opportunity. And so states are now being asked for the first time to say, what can you do at the state level to, in terms of funding to spread and scale, because home visiting has these incredible impacts and yet only meets a fraction of the reach and needs of eligible children and families. And so states are, McVie awardees are being asked to say, okay, what can the states develop in terms of funding to be able to then draw down a federal match at a rate of $3 to every $1 at that state level. So that's a real moment of opportunity to elevate commitment and partnership towards, improving systems of home visiting and early childhood systems.
Thank you so much to the 3 of you for such rich answers. And we actually have a very active question and answer session. So I'm going to throw this out just to the 3 of you, and feel free to chime in. The first question is from Esther Coleman, and she says, what is the best way for pediatric professionals to partner with professionals in other systems and institutions such as schools and other groups in order to help children of color to equitable outcomes and racially responsive care? And how have you done it or seen it most done effectively?
I guess as a practicing pediatrician, I'll take that one. Really, it really just depends on what level of commitment you have from an organizational standpoint. So if your organization is about it, a school-based health center is a great way to go, in the sense that you are awarded the chance to see the children in the school, but you also get to know the district and the leaders, and you know, you're usually their first call when something is coming up, and then you can put on as many programs and all kinds of stuff that you want to do for those children. I would also say on an individual level, it's pretty much the same thing. Get involved in the community. So go into the school, go to wherever the children are and spend some time, because then that you'll get a chance to see what the needs are and how you can support in whatever function that may be. It really is that volunteerism. And I know we get busy. Like I said, I'm still a practicing pediatrician. So I saw patients before I got on this today. I got notes. But it's to really bridge the gap. You got to come out of the box. You got to come out of the office and really see and be a part of the community and see where the needs are and do what you can to help with those needs.
And if you don't mind, I'm going to pick up on that only because both Dr. Lisa and Dr. Singleton are getting at the same concepts that I often speak about, but I have a very simple framework for people to kind of think about this whole sort of cross-sectional collective impact, coming together of different professions. And I started in the health space, obviously, as a pediatrician, but it's what I call a health 3.0 model. I think Dr. Leeser might have heard me present this once before, but it started from a healthcare financing paper, which I will be the first to say is not my area of particular interest. So it was a relatively dry paper, but really deep insights, and broke into this health 1.0, 2.0, 3.0. I have extrapolated. And if you think in broad brushstrokes, if the first half of last century was acute disease, right, acute illness, and then the second, and our whole health system developed around it, the way we covered what we had accessible, all of those sorts of things, and what our capabilities were. Second half of last century, we moved into chronic disease, which would be when I trained, right? And I distinctly remember when all of a sudden it's what do you do when patients are going to have to spend all this time in the hospital and they're going to outgrow their childhood diseases, which usually they didn't live past childhood, pediatric cardiology being one of the areas in particular. And so you have to change the system, right? So I always say we expanded the four walls of the healthcare system for long-term care and all these sort of chronic diseases and all these things that we hadn't really thought about. Now, I'm going to make the point now, all of these things still exist. It's not like we got rid of acute illness, and it's not like we got rid of chronic disease. But if you look at about the 90s, so basically as we headed into this century, we moved into health 3.0. And all I have to tell people, doesn't matter who the audience is, doesn't have to be medical. I say we moved into now an era of sort of what I call wellness and prevention, which is fabulous. But I always say, and here's where it gets really good for all of us and our shared interests, and anybody who's listening to a Hunt Institute webinar discussion, is two fundamental things happen. One, if you're going to go towards wellness and prevention, you go young. Right? Because everybody knows that if you're going to do prevention, the biggest return on investment, whether you're talking literal dollars or an individual child or a community, the younger you go, the bigger the return, right? As a general principle. So you go young. And the other is you go outside the four traditional walls of the healthcare system. And what I like to say, especially in front of my surgeon husband, is because as much as we still need surgery, you don't do prevention in the operating room. Right? Like that's not where we do it. So still very valuable, but that's where you're hearing all of us say permutations of what I do now. I literally make notes for myself where I write the number 4 and a square and then an arrow like outside those 4 walls, which is where when I started doing a lot of the cross sector work, and I say I shifted to a child family community centric model internally before it became a thing everyone was talking about, as opposed to a profession or an institution centric model. And all of a sudden, all I spend my time doing is hopping sectors, You have to learn to speak the business language and the healthcare language and which I knew, but then the education language and the early educators, which are not the same as educators because it's always been a divide. I won't get into education 3.0, but that's where you start to say, okay, that's where you get outside those four walls. And the example I use that's particularly relevant, Dr. Lisa was just talking about, Mississippi and their efforts in terms of really targeting developmental screening and early identification being one of the things on developmental milestones. Again, bread and butter pediatrics. What I started doing to make sort of a tangible case for this idea that we're now in this Health 3.0, which, by the way, I forgot to say, 1.0, we expand the four walls, and then I draw this big blob around and I say that's 3.0. We can't quite define the margins. We have to figure out how to get in and out. How do we get data in and outside those walls and do all the sharing between sectors? But the example I use is developmental screening. And in particular, the ASQ, when it started being used, right? So the Ages and Stages Questionnaire, as one of the approved, recognized in the pediatric world developmental screeners, was also being used in the early childhood sector, right? In early education and care. Not conceptually doing developmental screening in both sectors, but literally using the same screener in both sectors with the inability to share the information. It was like parallel universes. And in fact, I advise a purpose-built community in Florida I've been actively working with, where they're doing this integration of health and education, which we're all talking about. And they ran into a challenge when they were told on the pediatric side, they were integrating one of the very commonly used social determinants and sort of social services types of programs. And the program told the pediatricians, you need to do the ASQ screener, right? Like that's one of our requirements. And the pediatricians were using a different one at this, integrated services center. At the meantime, the child care center there, early education and care, was actually approved to do the ASQ in their center. Same patients, like same children, pediatricians were integrated in with a shared data platform that we've set up. And all of a sudden you're like, but they're requiring that the ASQ be done by the pediatrician, not by the early educator. That's why I'm saying we're seeing the system wrestling with itself as we recognize that health and education are integrated. I love former Surgeon General Jocelyn Elder's quote, you can't educate a child that's not healthy and you can't keep a child healthy who's not educated. Now it's a matter of on the ground with all these great organizations. How do we make that happen? How do we learn to speak this shared language around these things? How do we share data? And we always keep a child, family, community-centric mentality. As Dr. Singleton said, go where the children are, go where the families are, and then figure out how do we integrate around what they need.
I would just really build directly on that. And first, just unpack what you said around focusing in on, we're talking about a vision of thriving and whole family well-being and addressing social drivers. And you sort of unpacked directly to say like developmental screening, yes, is the bread and butter in pediatrics, but then let's take pause for a moment. Despite this being a formal recommendation, an expectation to occur in well visits, formally recommended by the AAP since 2006, understood to be important before then, integrated in state EPSDT. Some studies, like the National Survey of Children Health, place actual experience of developmental screening and implementation at 35%. And so we even have tremendous implementation gaps with some of the basics in pediatric, and we have to, just acknowledge that and start addressing those systemic and, policy and financing, equity related kind of barriers and opportunities there. And I'm so glad that that question was posed here, because I think what's also behind it is like, okay, like we get it conceptually. Of course, this makes such intuitive sense, but our systems aren't designed to do it. And what are the concrete sort of next steps to get there? And that's where I will put in the response to that a link within our early childhood development health systems evidence to impact center, a link to that engagement in action framework, which there's a lot in there that really does need some further unpacking and distillation, but it starts to get under the hood of specific sectors. Like, what does home visiting, what can they do, and how would partnership look within that? What is the role of childcare and childcare resource and referral agencies in partnership with the health center, with the health center. And so some of the next phase of this work is trying to think about how we can ever further develop opportunities to unpack and distill and bring the tools and opportunities to do that. And one effort that HRSA had funded years ago was the development of something called the Well Visit Planner. And that's an open source tool that anybody can access that has an array of Bright Futures recommended promotion, as well as comprehensive screening that, using the survey of well-being of young children and other pieces that are open source. And it generates like results from these family assessments and provides some support. But what's really important is that this is data that can be accessed across systems, because we are often telling our home visiting programs are expected to do developmental screening, but we don't want everyone doing screening, right? We want the focus to be on that strength-based promotion and setting that family-centered agenda and opportunity. And so that really strengthening the infrastructure and IT tools and other pieces that was part of that infrastructure of that comprehensive system is so important, and so often like underlooked and under-considered with the way that lots of research is conducted or funding priorities are established. So this is really important.
So in looking over the questions, we go from everything to how to promote lead testing to talking about the key QI skills to doulas to rural areas. It's really a broad array. So what I'm going to ask of the panelists is if you could take a look at those questions and just maybe, in some of those areas, address them. But I kind of wanted to encompass this more in a kind of a global question of how do you see the schools, whether they be childcare centers, Head Starts, elementary schools, how do you see the schools, the health community, the pediatric community, and families with the home visiting piece, of course, coming in? How do you see them? How do you see maybe one way that you could see them being able to work more cohesively than currently they're doing? Dr. Singleton, you have a model program in South Carolina. And Dr. Janney, you have these wonderful QI skills that we're talking about. But what is just kind of like one nugget of information? One way I've usually formed this question is, if I handed you a magic wand and you could change one thing, what would it be?
Well, I'm happy to jump in with a relatively short answer, because since Dr. Singleton does this as her professional big picture, but the approach I've taken in large part is translational, right? I'm like, we need a shared language, because if we're going to be working across all these areas, which does get to, I see the question about the key skills, I see the comment about the kindergarten readiness. What my premise was, I'm like, we don't need one more framework and one more list of skills and one more thing to memorize and one more thing to explain. What I was trying to do is say, if you could see in each of your sectors how what you're talking about and whatever language you use relates to this, and we all agree we care about this. And that's where the key skills have proven to do that, in the sense that it's going, I present them across sectors, like a crazy range of audiences. And it resonates, but it's meant to really emphasize. And somebody asked if I could do them. I can do them really quickly if you'd like, because I always run out of time at the end of my talks and then I have to say them fast. But most of the people in this audience, I think, will understand when I say, first of all, the 7 skills are meant to sound a little Dr. Seuss-like, but not too cute, because I want CEOs to use them at the same time. I want parents and early educators and pediatricians to use them. Me, we, why, will, wiggle, wobble, what if, right? Me, self-awareness, self-control, executive function skills, those identity, focus, attention, those sorts of things. Internal. We skills, outward facing, the ability to, I always say, short version, play well with others. right? But it's empathy and perspective taking and relational and all those aspects. Why skills, questioning and curiosity, asking all sorts of questions about how the world works. Will, motivation and drive, not just extrinsic sticker for whatever you did, right? Like a star chart. I'm talking intrinsic motivation and this sort of persistence and engagement and things. So me, we, why, will, wiggle. I actually made a skill because it's very well recognized that physical and intellectual restlessness go hand in hand, but especially in early childhood, we tell people to sit crisscross applesauce, on the spot on the circle rug. If you're in a childcare center, don't touch, don't poke, don't grab, don't interact. And everyone, but especially young children, learn best by physically interacting with the world, exploring it. So I made it a skill to kind of amuse myself, if nothing else. Me, we, why, will, wiggle, wobble, coming from Weebles Wobble, but they don't fall down. The egg-shaped toys weighted at the bottom, which is risk-taking. In a world that's rapidly changing, where you don't know what's coming next and you don't already have the answer, the ability to take risks and learn from your mistakes and grow gets into a lot of who's able to do that, right? And you get a lot in terms of the environment that people are in, whether they're even in a position to do it. And then the last skill is what if, and that's imagination, creativity, innovation, and all. But again, I always say, and each of those skills have a base. I did the developmental milestones for them. They have a basis in neuroscience, so you can tell parts of the brain. They have a very direct relevance to the business world, so I can get business people's attention based on the business and then say, now let me show you what it looks like early childhood.
Right.
But I also say for the what if skills, the culmination of the 7 skills, I always include hope. And I say, if you can't imagine a world better than the one you're facing or that you've been born into, it's not just your problem, it's everyone's problem, right? And that pulls us back to if we're going to be targeted about the audience. I mean, these apply to everybody. And I meant for the key skills to apply to some high-end business leader who, if he goes and talks to a policymaker, is going to impact decisions on policy. That's great if he wants the best for his kids. But my goal was, and now what about focusing on the children we know don't have the access and things? Because I know there's questions about disparities in race and things. My goal was, if I can get everyone to buy into a shared language and then pull it back to, then what does it mean for this group or this group or this group? It works really well. But I'll go with shared language. It wasn't as short as I meant it to be, but I answered like 3 questions when I did that.
You sure did. I love it.
Oh, Dr. Jana, I agree. I was going to say communication. So it's the same thing, because we are all out to accomplish the same goal. And the more we can work together and accomplish the same goal, the easier it is going to be on any family, any person that we're trying to help, regardless of we're talking about early education, but this is just any service line, adults, children, doesn't really matter. The more we can work together, have the same language, be able to translate the things back and forth so that it's not up to the family to bring this, bring that, take that there, or bring this here. Oh, you've got to take that there. Oh, no, it doesn't go here, it goes there. It's just going to streamline everything and just make it easier. So my biggest thing was communication. So yeah, I'm right with you, Dr. Jan.
Okay, so that's 2 magic wands. Let's bring it home with number 3.
Mine is incentivizing policy and financing to serve those things and others, which actually ultimately really requires like a mindset shift, because we know we don't need more science to prove the power of the early years and the opportunity and also the vulnerability of the early years for long-term outcomes. And we also understand that improvements as well as returns on investment happen also over the long term and across systems, the way that we do our sort of accounting. So instead of sending everyone sideways to try to like pick the widget that could move within one system to make the case, we need to start to love our logic model, I say, and really understand that trajectory between the system shifts and the coordination that needs to happen, and how critical and foundational they are to thriving children and families.
And I think, Dr. Singleton, you said it best when you said family is first teacher. And having the family be the core of when those decisions and how they're made, I think is so valuable and important. I dream of a world where the concentric circles of Brofenbrunner, instead of it being outside in, it's inside out. So listening to three of you today, I think that world is going to be a reality sooner than later. So I appreciate all of the great work you're doing. Any final comments or anything you would like to add?
Thank you for having me first and foremost.
Yes.
Like I said, it's always a pleasure to get to talk about something that I love and I live. So this
Mhm.
is
Yes,
awesome.
absolutely.
Final words is this is hard work, it's not easy work. But just keep doing it. Don't get discouraged. And even so even if you change one person's life, well, that's one life you've changed. So
Mhm.
just keep doing your little steps, because they will ultimately make to big things. So just keep doing it.
Dr. Lisa or Dr. Jana, any final words for us?
Well, I'll just jump in because, again, we seem very enthused, but that's in part because it's so nice to come together with other people who are working on this. And there are so many people. This is where I've had the benefit, and I'm imagining both Dr. Singleton and Dr. Lisa have too, but because I travel around the country and I do a lot of speaking and I do international talks on it, I'm actually stunned by how many people are really aligned, like that we have more in common than we don't, that people see this. And even if they don't see it, the message I give, and somebody asked where they can find my Weeble Wobble reference and things. From that one TED talk I gave, and this is not like praise myself for it, it's for all of us working in this space, I gave a slow talking 14-minute TED talk on basically the 7 key skills, but making this point of investments in early childhood and life trajectories. It's gotten 650,000 views, and that's where people find me, and talking around the world, but to different audiences who are really interested. And a lot of times I find they have no idea where to invest, at which point, like, at whatever level, whether they're policy, whether they're finance, whether it's a parent, whether it's a teacher. And so then being able to translate that back into concrete programs and efforts, whether it's home visitation or parents as teachers or reach out and read, those are all my go-to when I say, let me take this from the abstract systems level. Not everybody really geeks out of love your logic model. But when you take that and then you say, but here's what we're talking about, let me give you an example. Reach out and read. Reach out and read is a great example. You can tie it all in. That's what I like for people. But that way, realize you're not alone. You find a group who's doing this work and people are really eager to embrace you or support you because they understand it's not easy.
And Dr. Lisa, bring us home.
Sure. No, just with great gratitude, really that together piece, back to the MCHB strategic plan. And that's partnership is a key part of it. We often hinge our vision around accelerate upstream together. And I also feel, it takes action on all levels and partnership across all levels. And I do see real hope and promise in us moving together towards that shared vision. So just thank you for the work that you're all doing every day and your commitment to being here. And the only way we can get there is together.
Right. To looking at it right now, we had over 160 people listening to us today and a rich board of questions. So to the participants today, I want to thank you for joining in and thank you each for the work that you're doing. And to our 3 amazing doctors, I just want to say hats off and thank you. And everybody have an awesome rest of your day. Take care. Thank you.